So my name is Benhar Rezai. I'm from Helsinki, and I'm going to have a discussion regarding vertebrobasilar and saccular aneurysms. It's a common interest for both neurosurgeon, neurointerventionists, and neurologists in common, mainly because it's a disease that we haven't actually figured out how to actually treat it. There are some innovative solutions, but there is no final way to how to handle these cases. So because of this reason, we were able to collect from a few centers, about 10 centers around the globe, cases. And because of our relationship to these centers, the majority of them are actually surgical centers. So the amount of endovascular experiences in these series is fairly limited. So we have in Finland, Japan, United States, and Germany. So about the non-saccular aneurysms, there are some papers regarding its natural history, but the all series are fairly small. We are not really well informed how they behave, and some of them behave very benignly, and some of them behave in a malignant way. And one of the factors, depending, and it has shown in these cases, have been the atherosclerosis and the non-atherosclerotic cases. So there is probably several etiology behind of these, and there is a discussion that what kind of etiology is actually dolichoectasia is behind. Is it general atherosclerosis, or is it post-dissection situation where the aneurysm or the artery grows? But this is not the discussion of this topic, but rather that what happened to these patients. Some of the things that I want that you keep in your mind is that what the published study has already shown, that the natural history of dolichoectasia actually, it has prognostic factors. It has and it is dependent on the plasticity of the vascular system, and also the habituation of contralateral and especially the anterior circulation and PCOM arteries. So what we collected, basically, we collected about 321 patients with non-saccular aneurysms from these centers with treated in a way or other. And then from those, about 300 were dolichoectatic cases in vertebrobasilar system. So fairly large amount of number. And I'm going to discuss about the treatment and the difference in treatments. So that about a third of these cases were treated conservatively. It was seen that the best for the patient, and about 60% were microsurgical treatments and about 7% endovascular treatments. The reason for the conservative treatment in these cases have been, majority of them have been because of high age. Majority of these cases are predominantly males with high age, and they are too risky to go to any intervention, or they have actually ruptured, so it made no sense to do very complex revascularization or endovascular treatment in a very poor patients. So majority of them died, or we lost them in the follow-up. Usually in the Nordic system, we don't lose people to follow-up, but because this is international study from different centers and many different countries, they have different medical system, and that's why some of the patients are actually lost up in follow-up. I'm going to go particularly now in the microsurgical treatment of these patients, and I have divided these into 3 different topics. So basically, there is this very classic basilar trunk dolichoectasia, and then there is one or another vertebral artery dolichoectasia, and then there is a whole system of vertebrobasilar system, which is dolichoectatic. I start with the microsurgical treatment of the basilar trunk aneurysm, about 100 cases. We have divided them in basically publication by Dr. Lawton from Barrow. We discussed about having a flow reversal from taking the flow from the posterior circulation and out from the aneurysm to the anterior circulation and seeing what happens. From these flow reversal, which was done by revascularization of very highly skilled professionals, mainly by Professors Tanikavas and Lawton, among others, the 28 cases what we had, 20 of those patients died, many of them immediately. So any reversal of the flow from the from posterior circulation to suddenly change the hemodynamic to anterior circulation happened to have a thrombosis of the whole basilar and the immediate death or locked-in syndrome. Only few of these cases were actually survived, and mainly it was developed by the clip that I have designed. And there have been in a different discussion, the clip that I have designed. I'm not going to go too much details, but it's about the slow closing clip, what I have said, the Helsinki clip, where we are able to actually change the hemodynamics slowly. So in these cases, actually flow reversal functioned when we gave enough time to hemodynamic to habituate to the current situation. But overall, the mortality rate was fairly high. Then we have the second phase of these treatments, where we have the flow reduction, 42 patients of flow reduction in the basilar trunk dolichoectatic cases. The mortality rate was again fairly high, 60%. Only 12 cases actually had the curative treatment, and others actually suffered worse outcome than they were preoperatively. So overall, when we see this high mortality with the also flow reduction, the main causes that we are interested that which are those patients who actually survive. I come to those very shortly. Then our third phase of treatment was the revascularize the whole area and then make a distal occlusion of the dolichoectasia. Mortality rate again extremely high, 57%. Morbidity fairly high, and intact only a few patients out of these. And and when we go through this basilar trunk aneurysm with these dolichoectatic sacs, when we see that the mortality rate in overall was 62%, morbidity rate was 16%, and only 22% actually were intact. Technical failure of the bypass was fairly low when we are talking about extremely difficult procedures technically, where we are able to actually revascularize posterior circulation aneurysms and take the flow from anterior to posterior circulation. And so technical failure was fairly low, I think. So who were actually those who survived? I mean, these cases we discuss about which are those patients, what is the common with those patients who survive this deadly disease? And they are actually young patients who have no general atherosclerosis or calcification in imaging. And PCOM artery was actually able to habituate to situation and grow, which is very, very actually intuitive when you think about it, that if you change the circulation, you're able to change in a way that the nature actually takes care of it, then there is no malignant hemodynamic and it actually starts to function. And it tells about the arterial plasticity, and the clip of our design is actually stimulating this one. So this was from the basilar trunk. Then we go to the vertebral artery aneurysm, and there were 137 cases with trapping or proximal occlusion of 75%, and proximal occlusion only as a one option, 14%, and trapping in 80%. The Helsinki clip was used in these cases in 4 patients. So from those with the revascularization and trapping and proximal occlusion, we did a lot of this series where there were a lot of bypasses from occipital artery to pica bypasses, or V3, the radial artery graft to V4. So we did the bypasses all over, and there were, as you can see, there are some very skillful bypasses done by our Japanese colleagues, Dr. Tanikawa, V3 rag to P2, SDA, SCA, and occipital artery to pica bypasses. So they actually revascularize very fairly this area. How was the outcome? When we're talking about the trapping or proximal occlusion, the flow reduction was in 87%, of course, in trapping cases was 100%. 13 patients suffered from stroke, mainly in the pica area, and 4 patients died through the thrombosis of the basilar artery. Again, if the hemodynamic change was malignant, the basilar artery easily thrombosed. After a few cases, also centers learned that it's a good idea to start antiplatelet or anticoagulation drugs immediately. And in those cases, the patient survived only with small strokes. In the proximal occlusion, the flow reduction was 87 to 100%, and suffered from stroke 11 cases, and the mortality was 1, again via thrombosis of the VBA area, and this was very calcified patient with a lot of concomitant morbidities. What about the vertebral artery trapping? So of course, when you trap the case, it's 100% the reduction. Few suffered from stroke, but no mortality was done, mainly because the balloon test occlusion, of course, was done previously, and we were able to think that how was things done. The treatment of all over those who survived, again, there was having a common factor between the VBA dolichoectasia. Age was again pretty young, below 50. There was no general atherosclerosis or calcification arterial system, and the PCOM arteries were able to grow, showing the plasticity of the area. Then the whole system, the most difficult part, when the whole vertebrobasilar area is dolichoectatic, it's a sixth for the whole artery, and there is a very little that you can do. Mortality rate, astonishing 90% in flow reversal, and then another 10% locked in syndrome. We are very not able actually to do anything about this disease. And flow reduction mortality rate dropped to 84%, but still we had a lot of brain stem infarctions. When it comes in overall to microsurgical treatment of vertebrobasilar dolichoectasia, mortality rate was extremely high, and morbidity rate also. No one survived without morbidity. In all who survived, at least with some strokes, none of them survived without any stroke. So every single patient got some sort of stroke. One of the limiting factors was that all were above 50 years old. All of them had this general atherosclerosis or general dolichoectasia. The next slide is mainly something that you are interested in, endovascular treatment of these kind of cases. We got 22 cases with the dolichoectatic treatment of the dolichoectasia with the stent-assisted coiling in the saccular part of the aneurysm. So we thought that it's a pouch which is danger to rupture. And then there was these cases of 12 cases where the stent was put through the aneurysm to hold the dolichoectatic system in 12 of these cases. In stent over the aneurysm started to grow. We lost patient to follow up, and also many of them died. Immediate infarction was in 17 cases, and every single patient had infarction. None survived without infarction. And of course, this is a theory of the vasa vasorum. When you put a very highly stent in an already diseased section of the artery, the outcome is not necessarily a good one. The better one was with the stent-assisted coiling in the saccular part of the aneurysm, where we put, there was a coils put in the pouch, where it was seen as a danger part. And actually it worked in a few cases. And in the endovascular treatment, where we think about these cases, it seems to be that the pouch of the aneurysm can be treated if the area of the stent is not too long enough, and then you can specifically have a pouch where you can put a coil. But I think it's depend on the lock also. We don't know where are the vasa vasorums, are they going to grow or not? And also, of course, on other factors of the patients. So this has been the outcome of this serious scratch on this. Some rate of growth with the ones that we treated conservatively. There was we had the 16 cases, more than one imaging in the interval of 5 years. The 5 years have been chosen just mainly because we have seen on other series is that's a good number to be picked up. I mean, there is no other rationality behind this than experience that if you are going to see any sort of growth, it is going to happen after 5 years. Some of them, of course, grow faster. We got the 7% growth in 1 year for those which PCOMs had no responses. And then the ones that actually PCOM responses to the aneurysm, there was a 0 grow or 3% grow maximum. And the calculation where we start to actually calculate the volume of the aneurysm is the 25% of the parent artery. So when the parent artery starts to be larger than 25%, then we think that that's the part of the aneurysm. And this is something that we have just decided. There is no other rationale behind it. So this is the work in progress. There is no perfect solution, at least now. I think CFD studies are going to be needed, and also those biological matters which defines that which plasticity markers we are able to use, that we know that this patient is going to respond well to revascularization or other treatments. And vasa vasorum is something that I think endovascular people need to think about how to image those, or how to think that are they actually there, because we do have histological samples where we can see them. So it doesn't go that the argument that they don't exist, it's not very relevant. They do exist. We have seen them in histology. Sometimes they grow very fast, even in dolichoic acid, so they exist. But what the physiology behind the vasa vasorum during this disease, that is something that's unknown. So, any questions? Thank you.
Thank you. Thank you. For the patient with the anticoagulation?
Yes.
How long?
Forever.
How? Clopidogrel?
Yeah, and aspirin.
Aspirin. Same of the stent. Okay.
Yeah.
My question, do you use test occlusion before operation?
Majority of them, yes, majority of them go through balloon test occlusion before we do anything.
Thank you for this. Again, it's a major topic. You know, for the time being, the treatment we can apply, they are not giving good results.
Mm.
So the natural history is definitely better, even if it's not that good.
In some cases, yes, but we don't. The problem is that we don't know that which cases.
No, I mean there is a big difference between this arteriosclerotic dolicho-megabasilar artery and the dissecting aneurysm of the basilar. So forget about the dissecting and think about this one. I think that there are several ways to do the treatment by reversing the flow as far as you can analyze properly the arterial branches from the basilar. Where are the ICA? Where are the pica? Where are the middle cerebellar artery? Because depending on the site of the occlusion, you can increase or decrease the territory which is aspirating the flow. Of course, I have a nice topic on this kind of situation, but of course it takes too much time. The problem is the debate started a long time ago with Drake. When I was a young neuroradiologist, you know, Drake was a very famous neurosurgeon doing this kind of treatment, and he was involved in this tourniquet technique. And I was always claiming and speaking to him, this is a good technique. The real problem is you don't know where you put your tourniquet, because it's not depending on the vascular anatomy of the patient, it's depending on your possibility to approach the basilar. And this was a mistake. The concept of reducing progressively the flow to make the potential collateral circulation develops is the way to go. But you have to be able to select the location of the occlusion. And it's easy to do it by endovascular, because you can involve in the vacuum territory the pica on one side and exclude the pica on the other side. Or you can aspirate through the ACA and occlude at the middle part of the basilar and just use the PCOM. There are multiple ways to change the flow in the basilar, and I have multiple examples of these. The problem is it works with dissecting aneurysm, but it doesn't work with arteriosclerotic one.
Yeah, that is the
This
thing,
is
yes.
the big point.
Yes.
And obviously today, I have to confess that we don't have any solution for this, except the treatment of arterial blood pressure and, management of
the diplomacy.
diplomacy or diplomacy.
Yeah.
Definitely diplomacy. Yeah, you speak, you do something, it's not efficient or it's efficient, nobody knows.
But also, I think the fusiform basilar trunk aneurysm are different than the fusiform vertebral artery aneurysm.
Of course.
This is the first point. The second one is if the fusiform dilatation is segmental or it concerns the whole basilar trunk is another story. And the third thing is that we do not know how to define the imaging success of the basilar artery fusiform aneurysm. We know how to define the clinical success because it's clear cut, but we do not know how do we define the success of the intervention. Since we don't see the aneurysm filling, or we see the aneurysm getting stable over time, or it's a part of its filling because where the ICA is originating is a good imaging success. These are the points that we have always in mind, but also if it's a segment, not segmental, non-segmental basilar trunk aneurysm of not dissecting origin, I don't know the origin, atherosclerotic, mega blah, 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 it doesn't matter, but it's a non-dissecting origin, then we are in trouble. Our patients are in trouble. These are the, I saw your results, it's something like there are 100% morbid mortality, right?
At worst.
100% morbid mortality means that we shouldn't touch those patients unless if we have a better way to do.
No, I mean, the patients were very highly selected. I mean, those are the ones that the aneurysm still kept growing, had extreme symptoms like hydrocephalus, and you had to do something, otherwise the patient was going to die anyway.
Okay.
So that's why the acceptance of the high mortality or morbidity was accepted. Because
years ago we described you should do a craniotomy, posterior fossa craniotomy, put a adjustable VP shunt before to do any treatment for the basilar trunk aneurysm, etc., etc.
Yes.
But even if you do in that way, the success rate does not go beyond 40% to 50%.
I think Chris Stachner did an excellent job putting a series of this vertebrobasilar aneurysm. I think the essential problem goes back to what you start, and Jacques, again, you throw all this on the same bag as this vasculopathy, atherosclerotic, dissect. How do you define, and I think Edgar is going to talk about vessel wall imaging. I think we're going to need a way to redefine this. Okay, which segments are being involved? So, because today to compare this on the literature, if you go through that, I tried this exercise, it's totally frustrating. We have not treated abdominal aorta aneurysm, that is the equivalent of this on the belly, with open surgery anymore. So that's a much more approachable area than the brainstem. And I think we don't have the right endovascular tool there, but I think with the proper treatment of the vessel wall, with the stem cells and what is coming down the pipe, I think that might be the way to go. So we'll see. But the results are very humbling when you look at the surgical results for that endovascular as well.